Hello, everybody. This is Tammy from the National Child Passenger Safety Board. Thanks so much for joining us today. We'll be getting started in about 1 minute.
Good afternoon. This is Jim from the Child Passenger Safety Board, and I'm honored today to be your MC for this community education webinar, Where They Sleep Makes a Difference. On behalf of the National Child Passenger Safety Board, thank you all for joining us. And just a little bit of background on our presenter, Ben Hoffman. Dr. Ben is a semi-native of New Mexico. He majored in anthropology at UC Berkeley and attended Harvard Medical School. Upon completing his residency training, he was chief resident at Seattle Children's Hospital. And from there, he and his wife, Jane, who is also a pediatrician, spent 4 years on the Navajo Nation with the Indian Health Service, where he worked in community development and actually established a very strong child passenger safety program. He's nationally recognized expert in child passenger safety, and is a professor of pediatrics at Dornbecker Children's Hospital in Oregon, and is the vice chair for the community health and advocacy and director of the Oregon Center for Child and Youth with Special Healthcare Needs. He's also the medical director of the Tom Sargent Safety Center, and is currently the chair of the American Academy of Pediatrics Council on Injury, Violence, and Poison Prevention, as well as the director of the Community Pediatrics Training Initiative. He's very active in child health policy, advocacy. He's been a technician. He's been a technician since, I believe, 1998, and an instructor since 2003. So glad that he's taking the time to speak with us today. He's actually, he informed us he's at a conference in Dallas speaking on pool safety. So just gives you an idea of the wide background of his injury prevention knowledge and the work that he does. Please welcome me in joining Dr. Ben.
Thanks a ton, Jim. And thank you to everybody who's taken some time to spend with us this afternoon. I'm going to share my screen. This will take just a second. So we should be close to that. I need to do this. Sorry, I'm narrating it out loud. Hold on one sec. There we go. That's what I need. Apologize for that. Let me get this centered. And I just want to confirm that that is centered.
It is centered, Ben. Thank you.
Awesome. Thank you. So now we're going to jump in. And this talk is going to focus a little less on child passenger safety than it is on just basic principles of safe sleep, but it will intersect when we talk about kids sleeping in car seats, which we know happens all the time. So I really want to thank Tammy and Jim for this opportunity. And again, everybody who's participating, thanks for taking some time out of your day to do this. So when you look at this picture, I think what this brings out in us, our response to this picture is often, oh, that it looks cute. Nobody looks at this picture and thinks that baby might be in danger. Anybody who's ever had a kid understands how complicated it is. And as Jim mentioned, my wife and I are both pediatricians, and we were both pediatricians by the time we had our first child. And you would think there is no better informed consent than two pediatricians having a kid. And that's not us, but this is what we looked like and how we felt. We were blindsided by how unrelenting the fatigue and the terror of being new parents is. And there's a reason, because sleep for infants is the hardest thing that most of us are ever going to do. It's leaked into the popular literature, which is a reason this book sold millions of copies. We look at sleep, and every single one of us sleeps every day. We look at sleep as a restorative process, as a time to dream, as a time, as a good thing. And we don't think about sleep in this context of danger for kids, and we need to acknowledge that. What we're going to do today is we're going to talk a little bit about the epidemiology of preventable infant death, specifically around infant safe sleep. We're going to talk about the numbers. We're going to go into some of the alphabet soup. We're going to talk about what best practice is in the context of the American Academy of Pediatrics policy statement. We're going to talk about some of the controversies and myths. And then we're going to get into the issues around sleeping in car seats and other products that do similar things that put babies at risk, like car seats do. And we'll list some of the things that we can do as safety advocates, whether it's specifically around CPS or other aspects. I have nothing to disclose. And this will come as a surprise to nobody on this call, that unintentional injury is the leading cause of death for kids. If we look specifically, however, at kids 0 to 1, and this is data taken from the CDC between 2009 and 2019, as you can see, all unintentional injuries account for about 13,000 deaths. SIDS alone, sudden infant death syndrome, is responsible for almost 18,000. It is the single leading cause of death for kids under the age of 1. If you look at the green piece of pie there, that's congenital anomalies, which is a huge bucket of medical conditions that kids are born with, genetic or otherwise. The single leading cause of death is SIDS. Looking at it a different way, here's all the kids under the age of 1 and all the kids 1 to 18. You can see that yes, unintentional injury is as a class is less than a lot of the other issues. Their SIDS, with its 18,000 deaths, you can compare it to what kills kids 1 to 18, where you can see that unintentional injury is by far the leading cause. Within SIDS, 17,999 kids died in that 10-year period. Those are all the kids who died from cancer. So it's just about the same. You think about how much attention, how many commercials do you see for St. Jude on your television? And how much do people talk about sleep-related death for infants? But this isn't the entire story, because the SIDS deaths there are just deaths that got labeled as SIDS. We're going to talk about that in a sec. We have to also delve into the unintentional injury category. And if we dig into that a little bit, to those 13,000 babies who died, you can see that the single leading cause of unintentional injury death for kids under a year is suffocation, almost 11,000 babies. And within that category of suffocation, the classification of W75 within the ICD-10, which is the diagnostic Bible for medical conditions, all of those W75, which is almost 9,000 babies, were babies who died in their sleep. That classification is accidental suffocation or strangulation in bed. And in fact, 2/3 of all unintentional injury deaths for babies in this time period were sleep-related suffocation or strangulation. So you go back to here, we have to add another 9,000 babies who died in sleep-related scenarios to those SIDS designees to get all of the babies who died in their sleep. It gets a little bit complicated. SIDS rates vary from state to state. And you can see here, and this is data taken from 2015 to 2019, so a slightly different data set, that shows where SIDS rates are the highest. So it turns out the state of Washington, California, Nevada, Colorado, and you can see the states that have, those are the lowest rate states, and the states that have the highest rates are in the South and in the upper Midwest. So it's a very regional phenomenon. There are components and risk factors. And when we think about sleep, right, every one of us on this webinar today, unless you're a pediatric resident or a medical trainee, has slept within the last 24 to 48 hours. And when you go to sleep, you may be afraid of nightmares and that kind of stuff, but you're generally not afraid that you're not going to wake up. We need to think about babies differently. Because when you go back and take all of those babies who died, and we think about what those numbers mean, right? Those 18,000 babies who died of SIDS and those 9,000 babies who died of accidental suffocation or strangulation in bed, and think about it in a different context. Let's think about it in terms of school buses. So I want you to add, just, you don't have to put this in the chat, but think about how many, does anybody know how many kids a standard American school bus holds? So the answer is 72. Good guess, Will. Will Howard guessed 55. 72. And what that means, going back to our 18,000 plus 9,000, is about 10 babies a day dying in their sleep. And what that means over the course of a year is that it's this many school buses, 69 school buses of babies who die in their sleep. And I guarantee you, if it was 69 school buses of babies who are dying in school buses, there would be no school buses. People would be terrified of putting their baby on a school bus. But when we think about sleep, not just for ourselves, but for infants, think about the images we see on traditional media and social media. We see pictures like this, and that, and this, and those. And we look at these pictures and we think, wow, that's so cute. And we see images of where babies sleep. And this is taken directly from the HGTV, Home and Garden Television website. And if you Google HGTV nursery, these are the pictures you will get. We see these pictures. You look at these pictures all the time and you don't notice them. Maybe you do. But we look at those and we think, oh. And then we see this. And the first reaction I get from a lot of folks looking at that picture is, oh, that's sad. That baby looks lonely. He's not as happy as those babies. Look at that cute baby sleeping on that big fluffy blanket on the suitcase. Like, that's so cute. This baby looks alone and lonely. That's the only safe picture of sleep that I've shown. We don't see babies sleeping safely. We don't hear about babies who die in their sleep. Some of the people on this webinar might, because we're injury prevention nerds, but the general public doesn't. And we need to change that. I don't want people being terrified of putting their babies to sleep, but I want them to be worried enough to do the right thing. There's a big component of alphabet soup around sleep-related death that I'm going to jump into now. And I apologize for this, but I think it's important that we understand the terminology, which is a little bit complicated. So the first term we're going to introduce is SUID, or sudden unexpected infant death. It's sometimes also sudden unexplained infant death. This is the umbrella category. This is the 18,000 babies who were classified as SIDS plus the 9,000 babies who suffocated. All of those babies who died in their sleep under the age of 1 died from sudden unexpected infant death. All right, it's the umbrella term. And within that umbrella, there are 3 different classifications. The first most important is SIDS. And this is the technical definition of SIDS, that it is the sudden death of an infant under a year of age that remains unexplained after a thorough investigation. And what that investigation has to have is a complete autopsy. So the medical examiner doing a complete autopsy, a thorough examination by law enforcement of the death scene, and a thorough review of both the infant and the family's medical histories. And if after all that happens, nobody is willing to attribute a cause, it can be labeled as SIDS. And SIDS happens, but it turns out it doesn't happen as often as we think it does. SIDS tends to peak actual SIDS. So baby dies under the age of 1, full investigation, no answer, tends to peak between the ages of 1 and 4 months, but it can occur anytime during that first year, but 90% plus happen in the first 6 months. Right? Virtually all of it happens in the first 6 months. Not that the second 6 months are important, but we need to focus on the first 6 months. So that's SIDS. That's most of that 18,000. Sudden unexpected infant death includes those SIDS babies, the babies who die under the age of 1, have a complete investigation and nothing. It also includes all the babies who died under the age of 1 in their sleep that didn't get a thorough investigation. Something didn't happen. The death scene investigation didn't happen, the complete medical history review, or the autopsy. Something didn't happen. When we go back and look at that 18,000, that 18,000 that gets classified as SIDS, that's all of the babies who actually died of SIDS and all the babies who are attributed unknown cause, all right? The other 9,000 are this accidental suffocation and strangulation in bed, ASSB, which is a terrible name, but that's where there's been enough of an investigation and it's clear that something happened. That could be a baby who's bed sharing with their parent and the parent rolls over on them and suffocates them. It could be a baby who was on a pillow and rolled over and was found face down on the pillow, or a baby found face pressed against a padded crib bumper. This is what the numbers look like. So out of all of the 10 babies per day, the 69 school buses of babies who die a year in their sleep, around almost 40% of them have the full investigation and get classified as SIDS. About 35% don't have the complete investigation and get lumped into this unknown cause, and almost 30% get attributed to accidental suffocation, strangulation in bed. All right, so you think about it, almost a third, just to give you a sense of where things. And this is very dependent on medical examiners being willing to attribute a cause. It's very easy and there are a number of cases where a baby was found face down on a pillow and the medical examiner said, I don't know whether they turned face down on the pillow before or after they were dead. So this can be, there's a tremendous amount of variability in this. The US has an incredibly high SIDS rate compared to the rest of the world. You can see what things looked like in blue in 1990, and then what they look like in red in 2005. And you can see that we made progress. You see where we are all the way on the right-hand side, but we have a very high rate of SIDS, especially compared to other developed nations. And the burden of SIDS is not equally, and sleep-related death is not equally distributed across the population, because kids of color, especially American Indian, Alaska Native, and non-Hispanic Black kids, have the highest rates by far of all different causes: SIDS, unknown cause, and accidental suffocation, strangulation in bed. I showed you before that there was a difference in the US between 1990 and 2005, and this is why. That we became aware of the risk of sleeping face down or prone in the late part of the 80s, early part of the 90s. And in 1992, the American Academy of Pediatrics issued a policy statement that recommended that babies be put to sleep on their back, and then followed that with a massive safe sleep campaign. And you can see in green what happened to the SID, where the SIDS rate was prior to this recognition that babies should always sleep on their back, and what's happened since. The rate of sleep-related death has decreased by over 50%. It's amazing. But you can also see that between 2003 and 2007, it plateaued. And in fact, it's continued to stay plateaued. So this is data that goes all the way back from 1990 to 2019. And you can see in purple, the overall SUID rate decreased by over half and then has remained fairly constant, sadly. And that the rate of accidental suffocation, strangulation in bed has increased, which is partially due to things that we're going to talk about in a few minutes and products that are out there, partially due to the fact that sleep is really, really hard, and partially due to the fact that medical examiners have gotten more enlightened in how they do the classification. But especially in the context of what we know about child passenger safety, since this is the National Child Passenger Safety Board's presentation, we know that our work in CPS has made a huge difference. This is all of deaths, motor vehicle occupant deaths for kids under the age of 19 between 2000 and 2015. We've done amazing. We have decreased the rate of fatality by over 50%. And that has a lot to do with us and better laws and car seat checks and all of that sort of stuff. And you can see it starting to creep up a little bit, which scares me. But we all get how big a deal motor vehicle related death is. Here's what SUID looks like, sleep related death. And we're at a point now where SUID is as big a problem as motor vehicle related death, and we need to do something about it. So why is sleep a fundamental danger for babies? Why should we worry about it? What's different about them? So first of all, as a pediatrician, right, the first law of pediatrics is that kids are not little adults, right? They're just different. If you've ever met babies, they're really weird people, right? And especially younger infants. So the best explanation we have for why sleep is a risk for these babies is from the triple risk model. And the idea is that you have a baby who for some reason is vulnerable. And that vulnerability is a defect, a problem in their ability to wake up and protect themselves. All right. There's some fundamental difference in some babies' brains that allows them to sleep deeper. And literally what happens is they are at risk for sleeping themselves to death. And you take that baby who's at risk, you take them at the right time during that period of 1 to 4 months, and you give them an environment that increases that risk. And that could be sleeping on their stomach. It could be exposure to cigarette smoke. It could be exposure to soft bedding. It could be bed sharing with an adult. And you put those three things together, and it leads to horrible outcomes. This is where I think a lot of the money is going to be in the future, is figuring out how we can identify those babies who are at particular risk. And there's a lot of research that's being done into neurotransmitter stuff, the chemicals that our brain uses as messengers between cells, specifically serotonin. And that there are some babies who just don't respond. They sleep deeper and they don't respond as well to some of the things that should wake us up, whether it's external noise, external stimulus, lower oxygen levels, or higher levels of carbon dioxide, so less breathing, basically. We really don't know, but that's where the money is going to be. Until we understand that, we've got to go back to look at the key factors that we can influence. And that's where the science comes in. And that's where the American Academy of Pediatrics best practice recommendations come in. So the last time that a policy statement was published on SIDS and other sleep-related infant death was in 2016. The AAP published both a policy statement, which lists recommendations, and then this, which is the technical report, which is the best literature review you will ever find. Now, the task force on SIDS for AAP has drafted a new policy statement and technical report. It is under review at the AAP. I have seen it. It is awesome. It hopefully will be rolling out in January or February. There is nothing that's going to be earth-shattering, but there are going to be different emphases because we know a little bit more than we did 5 years ago, basically. The basics of what I'm going to tell you over the next 5 minutes will remain exactly the same in the policy statement coming up. So key components, and this goes back then to 1990, always place a baby on his or her back to sleep for naps and at night. Not on their side, not on their tummy. This alone has led to a 50% decrease in SIDS and sleep-related and SUID overall. And it's astonishing how many parents don't do this. One thing I want to mention is that, if being a pediatrician and an expert in child development, I know that somewhere between 3 months and around 6 months, babies will start to figure out how to roll over. Almost all babies by 6 months can roll from their back to their tummy. If you put a baby to sleep on their back, you have done your job. If they immediately roll to their side, that's on them, because if they can roll to their side, they can get back. If they immediately roll to their tummy, that's fine too, because we know if they can roll one way, they can roll the other. It's how we put them to sleep. We put them to sleep on their back. That's not what we see. We want to make sure that baby is sleeping on a firm sleep surface. And the ideal is a mattress in an approved crib or bassinet, something that meets the Consumer Product Safety Commission or CPSC standard. And that can be covered by a fitted sheet, but no other soft bedding in there. Nothing like this. So I presume that there are some people here who are affiliated with healthcare, people who work in children's hospital injury prevention programs. And the question always comes up, what about premature infants? Preemies very often in the NICU, in the neonatal ICU, will be placed on their tummies. There are some babies who have medical conditions that require them to sleep on their stomach. The same rules apply. As soon as it is possible to have them sleep safely on their back, you have them sleep safely on their back. And the ideal is to do that by about 32 weeks post-menstrual age. So that's for the NICU nerds out there. Room sharing without bed sharing for the first year of life. And when these recommendations came out in 2016, this was the single most controversial part. 90% of sleep-related death happens in the first 6 months. In that 10% of deaths that happen in the second 6 months, the rate goes up about twofold for babies who are sleeping in their own room as opposed to babies that were in a room with families. This gets a little complicated because, parents worry about, there are issues with, 9-month-olds waking up in the middle of the night and their parents not being able to sleep. And the question arises, what about parental fatigue and the risk for car crashes or the risk for intentional abuse or child abuse and that kind of stuff. So this is a place that I know there is no way to have a baby sleep safely if you put them to sleep on their tummy. There's no way to have them sleep on a padded surface, on a non-firm surface with soft bedding in there. I would not yell at a family, putting a 9-month-old in a different room if that's what they felt like they need to do. But if they can keep the baby in their room with them, it's probably best. Certainly for the first 6 months, there's a strong recommendation that we do that. And I know it's a little bit complicated. I hope that came out okay. As I said, the first year, nothing that could pose a suffocation or strangulation risk in the crib. No bears, no bumpers, no blankets. There are now a gazillion footy pajamas, sleep sacks, things that we can keep babies comfortable in that don't require this soft bedding. And, I've known babies who suffocated on pillows, on crib bumpers, on blankets in their crib. This is what a safe sleep space looks like, not that. This is taken directly from Bye Bye Baby's website. Other things, cigarette smoke, especially prenatal exposure, has a significant increased risk associated with sleep-related death, as well as secondary smoke exposure once the baby's born. Breastfeeding is fantastically protective. And that's one of the most important things that people can do. It definitely brings up issues of complication around the bed sharing versus room sharing thing. And there often is there has been some tension between the breastfeeding community and the safe sleep community, and figuring out how we build bridges there and get babies breastfeeding while not bed sharing is a huge challenge for us, and one that I hope we can work collaboratively on. And believe it or not, a pacifier can make a difference. And in order to explain that, and part of the reason we think room sharing without bed sharing makes a difference is we don't want babies to sleep too soundly. One of the myths that we're going to talk about in a few minutes, if you think about, the last person you knew who had a baby, right? The second question you ask after, was it a boy or girl, is, are they sleeping, right? And we define a good baby as one who sleeps. And we define success as a baby sleeping through the night, when in fact, babies at 1 month, 2 months, 3 months, 4 months probably aren't built to do that. There are a few who are, but a baby who wakes up every hour to feed is being the good baby. They're doing what they need to do. We need to flip the script on that as well. Now I want to go into talking about myths around safe sleep, because this is where a lot of the behaviors that we can help change come in. Myth number one, babies have to be swaddled. Human beings have been around for millions of years. We did not swaddle babies for millions of years. Babies can sleep without being swaddled. We have moved into a time where it's this expectation. And I see this play out all the time in the newborn nursery. You know, nurses who've been working for 30 years saying a baby has to be swaddled. Pediatricians talking about how a baby has to be swaddled. You go online to find out what it takes to be a good parent, and you think babies have to be swaddled. This is what the policy statement from 2016 says about swaddling, that it can be used as a strategy to calm babies, but there's a high risk of death if a swaddled infant is placed or rolls to the prone position. The reason is that if they roll over and their arms are contained, they will not be able to roll over backwards, or there's a good chance they're not going to be able to. So we recommend swaddling if a baby likes to be swaddled, it's okay, swaddle them. But once they get close to rolling over, you need their arms free. And there are ways you can do that without swaddling that include sleep sacks and other products, if that's what you feel like you have to do. A lot of the swaddling culture and this myth that babies have to be swaddled comes from Harvey Karp, who's a pediatrician who, then this is from a story in the New York Times that I'm quoting here. He published this book called Happiest Baby on the Block, for which he got a fairly substantial advance. And in it, he talked about the 5 S's, one of those S's being swaddling. And this became sort of the gospel. And part of what he says is this became adopted by a lot of people, and it doesn't come with any data. This is just what a pediatrician wrote in a book that has no scientific basis behind it, but it sold a gazillion copies. Babies don't need to be swaddled just because Harvey Karp says they need to be swaddled. Breathable mattresses make all the difference. So here's an example of a mattress that's marketed as a secondary mattress. It's not the mattress that comes with your pack and play or your bassinet or your CPSC approved crib. But this is one that they say is going to help protect them. There is no evidence that this makes any difference. It costs a lot of money. There's no evidence that it protects babies from sleep-related death. However, there's also no evidence they cause any harm. So if somebody wants to use one and spend their money, I have no problem with it. Just don't think that it's going to make a difference. There are people out there, including pediatricians, however, who take money to sell these things. So here's Dr. Jim Sears, the nationally renowned pediatrician and co-host of the Doctors TV show, talking about a breathable crib mattress being one of the best ways to protect your baby. That's not what the AAP says. I showed you what the AAP says. Here's another company talking about an independent blind scientific study that I looked for online and on PubMed, has not been published. There was an abstract that was produced, but this is not a peer-reviewed study, so it is not data. Here's another prominent pediatrician talking about this mattress being their number one choice for their patients and their baby's first mattress. And here are his qualifications. He's a member of the AAP, but what he says is different than the AAP. He is not a spokesperson for the AAP. Just because they say it doesn't make it right. It's safe to bed share if you have the right equipment. The reason it's dangerous is you're not using the right stuff, like this product, the Dockatot. This product, 5 years ago, this is what they had on their website. They specifically marketed this as a way to co-sleep and bed share. Guess what data exists? Absolutely none. And in 2016, the AAP said there's insufficient evidence to recommend for or against these, but there's no evidence that they reduce the risk of SIDS or suffocation or are safe, which basically is the AAP's way of saying, don't use it. We can't tell you this makes bed sharing safe, therefore you still shouldn't bed share. But they marketed very aggressively. So you can see Jennifer Love Hewitt, Kourtney Kardashian as influencers. All of this is not on their website currently, but it was. And then people, mama coaches and sleep consultants talking about what a great product this is, and parents putting these pictures online of this product, babies sleeping in this thing. Go back to what we know is safe, a firm, flat surface with no soft bedding in it. This product has a very soft cloth bedding, so it has the surface of whatever it's laid on. And if you put it on an adult mattress or a comforter, it is now not safe. And it has these huge padded sides, which look to me like nothing but a suffocation risk for a baby who rolls over. And in fact, we now know that there have been at least 12 deaths associated with products like this. And I'm going to talk about how we know this in a few minutes and why we don't know everything else we need to know about this product. All right, baby monitors like this product, the Owlet, being sold like hotcakes, $300. There is no evidence that they make a difference. And in fact, while the Owlet says they have published this paper in this journal, this is an open source journal. It was published as an abstract, not as a paper. And I don't actually, you can't actually review it. I tried. The AAP recommends don't use this. We know there is evidence that home heart and breathing monitors don't make a difference. Babies who have them have the same risk of SUID as babies who don't have them. So don't use them. The Snoo. I don't know how many people have heard of the Snoo or are familiar with the Snoo, but this is the smart bassinet that costs $1,300. Developed by Harvey Karp, who compared it to the development of penicillin. I'm not here to promote a product, but I'm saying if someone developed penicillin, wouldn't it be important to tell people about it? Well, he is there to promote a product because he's the owner of the company. He developed this. Now, this goes back to things we talked about before. We have no evidence that the Snoo is dangerous. That's fine. It actually meets CPSC standards with the exception of it requires a restraint to be used correct in order with, as they want you to use it. And the AAP does not recommend using no restraints to sleep for babies to sleep. But it's out there, and you could see again, Scarlett Johansson, Justin Timberlake, Gwyneth Paltrow, Zoe Saldana. This is out there too. And they've actually developed a rental program for families. I have no problem with somebody who, if they want to use it, but it's certainly, this is not going to help us address the equity issue for Black and brown babies. It is there, until we know that it makes a difference and there's science behind it, it's not anything that's going to be recommended. All right. Now the idea that sleeping upright at an angle is good for babies. Every baby reflexes in the same way that their muscles are wonky. You look at a baby's arms and legs and how they move in the first few months of life, right? There's not a lot of purposeful movement. There's just muscles working, but not in concert. And babies figure out how to do that over the first 4 to 6 months of their life. In the same way that their limb muscles are wonky, the rest of the muscles are wonky, including the muscle that closes the stomach off from the food tube or the esophagus, so that it should to keep it being a one-way valve and not let acid, that food goes down and not come back up, right? But anybody who's been around babies know they spit up all the time because that muscle, that sphincter, is wonky. And there is a myth out there that sleeping upright decreases this and makes reflux less likely. And that myth extends to nurses and physicians and a bunch of folks. But it turns out it's not true. It is patently untrue. We know, and we have known for a long time, that elevating an infant's head is ineffective in reducing reflux and isn't recommended. And we in fact know that it might make it worse. And the reason we know that is there are a lot of studies. This is the policy statement from the pediatric gastroenterology group from both North America and Europe. And what they said, first of all, and this was back in 1999, they first wrote this. We know that sleeping on a tummy is worse than sleeping on a back, that babies who sleep on their backs have a 10-fold increased risk of sleep-related death. Babies that sleep on their side have a 3-fold increased risk of sleep-related death. And they said specifically, the amount of reflux in babies on their tummy with the head, on their back with the head elevated is equal to or greater than babies who are lying flat. Lying upright doesn't change reflux, may make it worse. Okay. They specifically also talked about this position being related to infant car seats, which gets us to this, that babies sleeping in a car seat, swing, or other upright, semi-upright angled device is fine. This is what the AAP says in 2016, and I promise you this will get more emphatic in the 2020 version, that sleeping in these things are not recommended for routine sleep in the hospital or at home, particularly for young infants. Infants who are younger than 4 months are particularly at risk because their head can flop forward and block their airway. They can roll to the side and it can block their airway. It's just bad. We know that. And 2/3 of the deaths associated with sitting or carrying devices happen in car seats. And all of those happen outside of a car. Babies sleeping in the right car seat correctly used in a car are safe. The minute you take that out of the car, it's not safe. Now, I told you the first law of pediatrics is that kids are not little adults. The second law of pediatrics is you never wake a sleeping child, right? And that's part of why we have rear-facing only seats with detachable bases. But in the same way that you would never leave a baby alone in a bathtub with water, or you'd never leave a baby alone in a room with a wolf, you should never leave a baby alone in an inclined sleeping device, whether it's a car seat, inclined sleeper, bouncy, or whatever, without competent, complete, thorough, constant adult supervision. Because we know bad things happen. Car seats that are not installed correctly in the car with the angle being too upright are at risk. And then car seats used outside of the car are at risk. And there have been studies that have shown, and this gets back to car seat tolerance screening and the testing that we do on premature infants and infants who might otherwise be at risk for breathing and heart issues when they're sitting in an upright position. We know that sitting in a car seat at the correct angle, according to the manufacturer, at that 30 to 45 degrees from vertical, whatever the manufacturer says, decreases the oxygen levels of babies. We know that it increases the risk of sleep-related death. We know that it increases the risk for bad events, brief unexplained events, which used to be called apparent life-threatening events. So near-miss SIDS, it used to be called as well. A lot of kids who have these experiences are in the car seat at the time. Again, 2/3 of the deaths associated with sitting devices were in car seats. And we need to understand this better. Part of what we think happens, in addition to the issue of positional asphyxia, the head flopping forward or to the side, physically blocking the airway, is that babies sleep deeper when they're at an angle. And if you talk to families who struggle with their infant sleeping, because everybody does a little bit, you will hear people say, no, I put my baby to sleep in a swing, or I put them to sleep in the car seat because they sleep longer. And the parent thinks that's a good thing. I'm helping my baby sleep longer. That's good for me. It's good for my baby. what this data shows is the comparison between babies who were screened prior to discharge from the NICU, car seat tolerance screening, babies who failed one test and babies who failed more than one test. And this compares what happens to them when they're sleeping. And what the darker things you see on the right-hand side with a p-value, where it says p-value, basically what this study showed is that babies who are more likely to have significant desaturation, low oxygen levels, or low heart rates in car seats slept deeper than babies who only failed once. They slept deeper, they breathed less, and they had more obstruction. This means babies sleeping at the angle, some of them are going to sleep deeper and sleep themselves to death. This is a real thing. So the recommendation is that we use car seats in the car, right? And we teach this in the curriculum. We also need to be realistic about it, right? And make sure that parents understand outside of the car, a car seat is not a safe place for a baby to sleep. In the car, used correctly, it is a safe place. Outside, it is not. And you need to make sure that baby is either not in that car seat or somebody is watching that baby like a hawk. Let's get back to some of the world of infant products. FisherPrice, in 2009, produced this, the Rock and Play. This was a product that was specifically designed to have infants sleep at an angle, and that angle was about 30 degrees from horizontal, right? So when we talk car seat angles, we're talking 30 to 45 degrees from vertical, so 45 to 60 degrees from horizontal. This product sat at about 30 degrees from horizontal. And it was developed by an engineer at FisherPrice whose son, who you can see Jake there, the real life inspiration, had reflux. And she heard from her pediatrician in the early part of the 1990s that a baby with reflux will reflux less if you put them at an angle, which we know to be wrong, but that pediatrician said that. So she developed this product. And it went to market. And it sold like hotcakes. And this is what parents said about it. It's the best thing that happened to infant sleep. It's comfortable, easy to take place. It's the only way I can shower in the morning, says a mom. So it was developed because a pediatrician said, you should do this. And in developing it, FisherPrice, you would think they would talk to pediatricians and say, is this a good idea? Is it a good idea to have babies sleep at an angle? The doctor that they talked to was a physician by the name of Gary DeGeer, who was a family practice trained physician in Texas. And you can see what's highlighted there. They asked this doctor in 2009, is it okay to have babies sleep at an angle? And this doctor said, pediatricians recommend babies with reflux sleep at 30 degrees. This is fine. Or sleep in a car seat overnight for months or even a year. Back to Sleep campaign places children on their backs in elevated positions of the head is fine. He is not aware of research on this. We'll do a quick search. So turns out there was research on this, a lot of research on this, and there was never any follow-up on this. This is all of the medical advice that went into the development of the FisherPrice Rock and Play. And they sold 5 million of them. And a number of other companies started selling these too. And what you would hear over and over again is that parents love them because babies slept longer. What do you think that means? Babies slept longer, they slept deeper. They sleep deeper, maybe they can't wake up, and maybe babies will sleep themselves to death, which is exactly what happened to this baby. This is Ezra. This photo was taken a couple of weeks before he died in this Rock and Play. May 31st of 2018, the Consumer Product Safety Commission issued this warning, alerting consumers that there are hazards associated with incline sleep products. May of 2019. We didn't know much more than that. They just said, we need to be aware of this, use it according to manufacturer's recommendation, which included use of a restraint in the product if there is one. Flash forward 11 months, and on April 5th of 2019, the Consumer Product Safety Commission issued this warning, saying we're warning specifically about this product due to reports of infant death. And you can see on April 5th of 2019, the CPSC, they said they were aware of 10 deaths associated with this. So there was a warning. A year ago, there was concern, but no details. Now there's a warning because we know of 10 deaths. April 5th, 2019. April 8th, 2019, 3 days later, a reporter named Rachel Peachman at Consumer Reports publishes this. 32 deaths. 3 days later, it went from 10 deaths to 32 deaths. Crazy, right? How did Rachel Peachman know about the 32 deaths? It's a little bit of a long story, but it turns out she asked for data from the Consumer Product information from the Consumer Product Safety Commission through a Freedom of Information Act. And inadvertently, she was sent unredacted information from which she could identify 32 specific deaths. And that event, 10 deaths to 32 deaths in 3 days. Now, did the Consumer Product Safety Commission not know about these other 22 deaths? They did. We're going to talk about why they only mentioned the 10 in a minute. But this led the American Academy of Pediatrics to do something it had only ever done once before on April 9th, the day after Rachel Peachman's story came out, urging a recall of the FisherPrice Rock and Play. And that's what happened. Within the next 2 weeks, there was a recall on the FisherPrice Rock and Play, as well as products from a couple of other manufacturers. And this was good because it got them off the market. However, thinking about the equity piece, this was a picture I took at a consignment store in Oregon in June of 2019, about a month after the recall was issued. And you can see nothing but incline sleepers on the left-hand side there. People didn't send them in on the recall. They got rid of them. They sold them. And where do they go? To people with lower incomes, which are disproportionately going to be in higher rates in communities of color that have a higher SIDS risk to start with. Now I'm going to flash forward 5 more months. So the recall, end of April in 2019, September of 2019, the Consumer Product Safety Commission hired a researcher to examine what happens to babies in these incline sleepers that may put them at risk. And this researcher they hired is that principal investigator, a woman named Erin Mannon, who is a biomechanical engineer and the only biomechanical engineer in the country who's doing work on babies. She's brilliant. And she did a study that put babies flat, 10 degrees, 20 degrees, and then 30 degrees. And what she did is she videotaped them. She put all sorts of monitors on them, looking at their breathing and their oxygen levels and their heart rate, their muscle use. And then she also put them in the same suit that they use for motion capture in the movies. So what made Gollum in Lord of the Rings, that allowed them to look at the baby's movements, correlate that with their muscles firing and with their underlying vital signs, their breathing and their heart rate. Brilliant stuff. And what she found is that none of the incline sleep products that were tested are safe for infant sleep. All products that were tested are unsafe. There is no incline sleep product that were examined that are currently safe for infant sleep. The product category through the Consumer Product Safety Commission and the ASTM, which is a whole nother thing, should be significantly modified to ensure a safe environment. And that an incline of 20 degrees or greater is not safe. Okay? This is science. It is not safe to have a baby sleep at an angle higher than 20 degrees from horizontal, from flat. Whether that's in their car seat outside the car or a swing or anything else. And now there's science behind it. What about boxes? And I apologize, this was supposed to have a animation in it and it doesn't. I apologize for that. I'm going to skip ahead. We know nothing about boxes. I want to point out, this is a baby box from a company in the United States. It costs $70. This is a cribette from Cribs for Kids. It meets Consumer Product Safety Commission standards. There are no Consumer Product Safety Commission standards for this. This is safe. It's $80. A kid can use this for the first couple of years of life to sleep safely. This can only be used until a baby starts to roll over at 3 to 4 months. That to me is a no-brainer. We talked about Dockatots. Why do we not know more about these in-bed sleepers? Because there is a rule at the Consumer Product Safety Commission called Rule 6B. And what it does is it prevents, sorry, I need to go ahead to this. Rule 6B prohibits the Consumer Product Safety Commission from giving any information to anybody about a product that might be dangerous, that could identify that product without express permission from the manufacturer. And this is done to protect the manufacturer, which I understand. But this is why the Consumer Product Safety Commission was willing to talk about 10 deaths on April 5th, because the manufacturer said you can talk about 10. They didn't want them talking about the other 22. And this hides the truth from us. And when it hides the truth from us, babies die. All right. I'm going to end in a second and I will stick around for questions. I'm sorry I ran a little bit long. I would ask you guys, if you see something, say something. This is a picture that comes from a TV ad that aired in Portland, Oregon from a real estate company. It was one of those TV ads that goes from a couple meeting and starting to date to then getting married and having a baby and buying a house and then a bigger house. This was their first baby. And this is how they showed the baby sleeping in the commercial. This is the tweet I sent that morning, shaming them for showing this ad. And this is the tweet they responded with the next day. Thank you for bringing awareness to this issue, and good thing mom and dad were there to turn the baby over after the photo was taken. They took this commercial down and we helped them produce a commercial that showed babies sleeping safely. This is a picture that was outside of our NICU at my hospital, showing a baby not sleeping safely. I brought this to their attention. They took it down the next day. This is the Bible of neonatology that was published in 2016. And the authors had no idea. They looked at this picture and said, we want a baby that represents a community of color. And they didn't even think about what they were showing in terms of safe sleep. This is the cover that actually got published. And that's my email address. I would be delighted to answer questions, to respond to any concerns or have a discussion. I'm going to stop sharing now and open things up for conversation and questions. Like I said, I apologize for going a little bit long. I will stick around as long as anybody wants to stick around. I want to thank Tammy and Jim for this opportunity, and for everybody who was able to participate for being a part of this. Thanks.
Thank you, Dr. Ben. Excellent information, and thanks to the 170 CPS technicians who participated today. Just a lot of great questions, and I think what we can do is maybe put together a Q&A and post it when we do post the presentation as well. Tammy, are we able to continue and answer some questions?
Yes, we can continue.
Okay, so then I jotted down just a couple that were probably most pertinent related to child passenger safety. When parents ask how long can babies safely sleep in their car seats in the vehicle, what advice would you have as far as addressing that?
So I certainly would recognize that being in the car seat may make babies sleep a little more deeply than normal. Yeah, and I think there's a huge difference between the first ride home from the hospital, and a 9-month-old. I think parents, need to know their baby. In general, for the first little bit, when a baby will tell you when they need to get out of the car seat. In general, I think it's going to be an hour and a half to 2 hours. It makes me nervous to go longer than that for the first couple of months of life. I always like to recommend having, an adult in the back seat when possible, especially for a longer ride. But if the car seat is used correctly, from what we know, it should be safe. I think it's hard to come up with an absolute number for that. But again, I default down to, 90 to 120 minutes for a younger baby, because that's how long, babies in the first few months of life are going to wake up somewhere between every hour to 3 to 4 hours. And in general, it's going to be around that time period.
Great. And do you have any suggestions on how to address new parents and caregivers on the use of unsafe items?
Yeah, I would go back to, I think, presenting the idea that 10 babies a day, that we lose 10 babies a day to unsafe sleep, to sleep-related death. And a lot of that has to do with babies who who sleep in unsafe scenarios, either at an angle or with soft bedding or bed sharing with a parent. Not to scare them, but just to help them realize. I think one thing that's really important, and we know there is literature to support that this works, is role modeling the right behavior. Making sure that from the moment a family, an expectant mom gets in the system, all they're seeing, ideally from prenatal to postpartum, is role modeling safe sleep, so that we're not putting babies at an angle. We're not swaddling babies and laying them on their side because that's what a nurse who's been practicing for 40 years has done for 40 years. We're not allowing pediatricians to put that, to tell people to, we're not allowing pediatricians to put the head of the bed at an angle. We're role modeling the safe, the safe sleep for the entire time. And I think we need to start working with our maternal care providers, with midwives and OBs, et cetera, to get them involved in this, because, that the postpartum, being in the mother baby unit or the NICU is the worst time to work on behavior change and helping people learn, because it's terrifying and you're exhausted. Yeah, go ahead.
And you were very influential in helping pass a crib bumper legislation in Oregon. Is that correct?
Yes.
So have you seen any process on the national level?
No, actually, the Consumer Product Safety Commission in June did issue a proposed rule that would ban all products that identify themselves as related to infant sleep that don't conform to the crib or bassinet standard. So what that would do is take boxes, incline sleepers, in-bed sleepers, and those sort of things off the market. The Consumer Product Safety Commission, there's a really complicated history around crib bumpers and the Consumer Product Safety Commission. Although there is a bill now in Congress that would ban crib bumpers. I'm hoping it will advance. There are several states, New York, Maryland, and now Oregon, that have banned crib bumpers. The city of Chicago has banned crib bumpers. There are not a number of the mass retailers, so Amazon, Walmart, and Target, all stopped selling crib bumpers. So I think that's progress. I do think the idea of crib bumper ban still is good, because it raises the issue of awareness. And they're designed, the law we passed in Oregon was to make the marketing, distribution, and sale of bumpers a civil penalty, and not to demonize parents or caregivers who continue to use them. But we can do better with that.
Great. Early in your presentation, the slides that you've shown with the rates of SUIDs and SIDS, state by state, any theories as to why the states that had higher rates had them?
So I think a lot of it has to do, well, some of it has to do with how deaths are classified. And there are some states where, a sleep-related death might not get classified as a sleep-related death. Some of it has to do with definite demographic differences. We know that rates go up in communities with lower incomes. We know that rates go up in, like as I mentioned before, communities of color. And where those things intersect, we can see much higher rates. I think that's a lot of what happens in that belt along the Southeast US. But there's so much variability and so many unique aspects to this whole conundrum of SUID that it's really hard to know. And it gets back to, like so much around injury prevention, you need, so much of it is local, and you need to understand your community and what its assets are and what the needs and risk factors are.
Okay. When the new AAP recommendations come out, will they still recommend sleeping in the same room from 6 to 12 months?
Yes.
Okay. And has the AAP considered, or has the AAP had any sort of a task force or any group that's reached out to retailers?
Oh, absolutely. Yes. But there's only so, that the AAP, we have the force of recommendation. We can't enforce anything. And so, so I will give you a very specific example. And I would welcome anybody to do this. If you Google Dish Network, the babysitter commercial, there's a commercial that came out 2 weeks ago that shows a pair of grandparents, an African-American couple, with their, what is identified as their grandbaby, and instructions from the parent, which says bedtime instructions, the baby sleeping in an inclined swing, obviously for the purposes of sleeping in that thing. This is a major provider of satellite TV, and it's co-branded by Amazon Prime because it was a promotion with their streaming service. Folks at Amazon don't know anything. What do you do about that? How do we change that? I've been trying for 2 weeks to identify who the ad agency was. I've sent emails to Dish. I've tweeted at Dish, and I've heard nothing. So it gets a little bit challenging. I think the more that we can get on board together, the better off we're going to be about this.
Great. A couple of questions on when the new guidelines will be published.
Yeah, January or February. It's going through the review process at the American Academy of Pediatrics, and I guarantee you it is a massive priority. But there is a process, and sadly, it always takes a little bit longer than we want. So the estimates I have heard is somewhere in January or February. I would expect that.
Okay. And how, as injury prevention professionals, how do we get pediatricians on board?
So I think, first of all, reach out to them. I think the right people will respond. I think, that pediatricians don't like to be lectured at, but but we like to learn. And I think if there are ways that you can help them, provide that you can provide resources to them, education. I think, as with most things, it starts with relationships. Start with your pediatrician. Make sure they know about the AAP's recommendations. If you live in a place with a children's hospital, if there's an injury prevention program at the children's hospital, or they're involved with Injury Free Coalition for Kids or with Safe Kids, connect them with that. Most pediatricians want to do the right thing. We just have a lot to do. It's busy, and but the more we talk about it, the more we can role model the right behaviors. Cribs for Kids does have a certification process. program for birthing centers and hospitals. Not something you can suggest. Get them in touch with me. I'd be delighted to talk to them.
And along those lines, any sources for to direct families to, as far as maybe printed materials or even just websites? Do you have any that you recommend?
Yeah, so the AAP has a lot of good information on healthychildren.org. That's the AAP's family-facing website. First Candle, Safe Kids, and First Candle has a bunch of good stuff. Safe Kids has a lot of good stuff. I mean, it's all the usual suspects. But for families, I think the stuff on healthychildren.org is especially good because it's specifically focused for them.
Okay. And here's another one that's directly in line with child restraints. How do you suggest we address safe head positioning in child restraints, specifically when particular seats have greater tendencies for unsafe fit? I think along those that question too, the use of blanket rolls as well for positioning.
Yeah, so I think there's a huge, when we're talking about the issue of correct fit, I think there's a huge difference between a premature infant and a healthy term infant compared to a 3-month-old or a 4-month-old. I think we all know as car seat nerds that just because a car seat may meet the weight and length, that a baby may fall within the weight and length limits, that it's not always going to be the right fit. So I think it's incumbent on us to make sure to do what we can to promote the best possible fit to the extent that we can. I think the issue of the rolled blankets gets back to ultimately what does the manufacturer recommend, because we're never going to go against what a manufacturer recommends. If the manufacturer says that it's okay, I would ask first, after that, is it actually necessary? Because babies can turn their head to the side. That's fine. It's really the issue of the head flopping forward that I really worry about. And what's going to happen to the baby during the course of travel, because you can position them correctly, at moment one, but over the course of time, if they slide down and they get into a different position, that's what really worries me. So I would love to see more data, and some real world studies about, the issues of fit and rolled blankets and all that sort of stuff. Like I said, you never go against manufacturers' recommendations, which we all know. But I would try and keep it as simple as possible, because we know that the more that we try to complicate it, the more we ask parents to do, the harder it gets for them to do right.
Sure. And one last question, and as I said, we'll try to put together a Q&A of some of the questions. Well, actually, of all of the questions.
Great.
So we make sure that we've addressed them. So when we're doing the car seat tolerance screening,
yes,
should we only be doing it for a max of 2 hours instead of 3 hours? Since there's a kind of like a guideline for how long a child should be in the car seat.
Yeah. So it's a great question. The simple answer to that is we don't know. The recommendation that was published in a clinical report in 2006 is 90 minutes to 2 hours, that every baby should be screened for 90 minutes or up to 2 hours if the duration of travel is longer than 90 minutes. Putting a baby in a car seat for 4 hours, I don't think is going to help anybody. And 3 hours, nobody ever said 3 hours. What was in that clinical report is 90 to 120 minutes. One thing we know from surveys of what people are doing in both mother baby units and in NICUs is that most places are doing 90 minutes for the majority of babies. And if the duration of travel is longer than 90 minutes, they're doing it for 120 minutes. That's what the majority are doing. And then saying after 120 minutes, you need to not stay in that car seat, that you want to stop every 90 to 120 minutes, which makes sense for a baby going home for the NICU who's probably going to need to feed and do all that stuff. The same way you need, as a driver, you need to get out and stretch your legs and pee from time to time.
Sure.
But we don't have real hard science on that. And I do want to mention that we are in the process. We have filed an intent to actually develop a policy statement around car seat tolerance screening. And what I need to tell you is it generally takes 18 to 24 months to go from intent to actual publication, but we have the authorship group together. We're starting to work on the technical report, which is that literature review. And so my intent, and I will promise this to the extent that I can promise it, is that we will have a policy statement within the next year or two that spells out specific guidelines, and that it will not conform with Canadian Pediatric Society and say we shouldn't be doing this.
Great.
We will recommend it.
Okay, so that wraps up our questions for now, and we'll be sure to get that Q&A out when the presentation is posted. Tammy, I think you have a couple of slides to show.
I just want to, we can end with the last one, Jim, if you just want to share what the next webinar is, and I have that slide up.
Okay, and okay, so our next webinar coming up, again, another community education webinar, will be Tuesday, November 30th at 2 p.m. Eastern Time. And it's a toolkit for tribal partnership development. We've got some excellent presenters, Tabitha Harris and Chata Ohoyo. I'm sorry if I mispronounced that name. I know Tabitha from Kids in Motion, and she does an excellent job. So looking forward to that, and please join us for that. And again, thank you to the 175 participants today. Definitely a lot of interest in this topic, and gives us some great ideas on where we can go from here and discuss this topic some more. So thanks everybody, and have a great rest of your day.